Today I start disease of the middle ear. Today's topic is acute otitis media. By definition, acute otitis media, it is acute inflammation of the mucoperiosteal lining of the middle ear cleft. Now what is middle ear cleft? You read in anatomy of middle ear. It comprises of Eustachian tube, middle ear proper, including attic, adytas, antrum and mastoid ear cell system. So it is a inflammation of the mucoperiosteal lining of 5 components of the middle ear. It is not the infection of the middle ear proper. It includes all the 5 subcontinent of middle ear cleft. The types of reaction of the inflammation depends on virulence of the bacteria, resistance of the host, and promptness and adequate management of the infection. Severity of the clinical manifestation also depends on the degree of pneumatization of the mastoid. In anatomy of the middle ear, you know there are 3 types of mastoid ear cell system. One is sclerotic mastoid, where only antrum is present, no ear cell is present. Second is highly pneumatic mastoid, where plenty of mastoid ear cells are present, or different groups of mastoid ear cells are present. And third one is diploic type, that is hypocellular type of mastoid. In case of very high cellular mastoid, the infection spreaded all around the mastoid ear cells. So area of inflammation is much more in case of pneumatized mastoid, and where there is complication and resolution is very difficult by medical management only. Now etiology of acute otitis media. It is common in children between 2 to 5 years. It is estimated 70% of the children have 2 or 3 attacks in their age. Mean age is 3 years of age. Eustachian tube, why this occurs in child? Very frequent infection. There are several causes. Main cause is Eustachian tube. In case of child, I already teach you, it is shorter in length and more horizontal in position. That's why infection from nasopharynx easily goes into the middle ear cleft. Second, more prone to upper respiratory tract infection and allergy in case of child. In case of child, immunity is not developed fully. They are the age of developing immunity. Active immunity is developing in case of childhood. And sex, there is no sex difference in case of male and female. Predisposing factors. These are the predisposing factor: upper respiratory tract infection, URI, common cold and influenza, adenoid enlargement. This is very important. In case of child, there is adenoid. Adenoid is a aggregation of lymphoid tissue, and it guards the aerodynamic pathway, that is the nose and nasopharynx, so that it catches the aeroallergen. Thereby, they are developing the active immunity. And this adenoid is automatically resolved at the age of 8 to 10 years of age. Adenoid is resolved automatically by revolution. So, in case of child, adenoid is enlarged. That's why there is recurrent infection of adenoid. That is called adenoiditis. And as it is very close to the Eustachian tube, the infection goes into the Eustachian tube, causing recurrent middle ear infection in case of child. Acute exanthematous fever, nasopharyngeal, any SOL in the nasopharynx like tumor, polyp, and postnasal packing. Chronic sinusitis and cleft palate. Cleft palate, there is associated Eustachian tube dysfunction due to malfunction of Eustachian tube related muscles. Risk factor, bottle feeding. There is any not proper way to feed the child by bottle feeding, there is chance of nasopharyngeal incontinence, giving rise to middle ear infection. Allergy, overcrowding, poor socio-economic status, smoking in the family, having otitis media, viral infection, hereditary and genetic factor. Other associated diseases like cystic fibrosis, immunodeficiency, Down syndrome, cleft palate, ciliary dyskinesia, that is called Cartagena syndrome. These all are causing stasis of the secretion, thereby inviting infection in the middle ear. Now bacteriology. Staphylococcus aureus, Streptococcus pneumoniae, all are gram-positive cocci. Monoxella catarrhalis, Haemophilus influenzae, E. coli. E. coli is a gram-negative bacillus. It occurs in case of small 6 weeks of child. In case of child, infant of 6 weeks. Bacteroids and other gram-negative organisms also can cause. Now, route of infection through the lumen of the Eustachian tube. It is direct infection through the lumen of the tube. Submucosal lymphatics around the Eustachian tube. That is peritubal lymphatic system. Through the lymphatic system, infection spread into the middle ear. Tympanic membrane perforation. If there is already a tympanic membrane perforation, exogenous source of infection goes into the middle ear, can cause acute otitis media. Bloodborne. Bloodborne is rare. In case of septicemic infection, blood septicemia, then can cause middle ear otitis media. Now, pathogenesis of acute otitis media and symptomatology. There are 5 stages as per progression of the disease. There are 5 stages according to progression of the disease. Stage 1, stage of tubal occlusion. What happened here? There are edema and hyperemia of the nasopharynx and Eustachian tube, causing blockage of the Eustachian tube. Thereby, there is absorption of the middle ear entrapped air by the blood vessel, thereby causing a negative pressure inside the middle ear. Negative pressure is developed in the middle ear. And this negative pressure gives rise to some kind of effusion in the middle ear space to compensate the negative pressure in the middle ear. And that is not clinically detectable. This phase is clinically not detectable. Clinical feature of this stage is ear fullness and mild otalgia, no constitutional symptoms. Autophony. What is autophony? Patient hear his spoken word as echo in his ear, as echo in the ear. It is due to mild conductive type of hearing loss. What are the signs in the stage 1? Tympanic membrane is retracted. What is the cardinal sign of retracted TM? You can see clinically shortening of the handle of malleus. There is posterior rotation of the handle of malleus. Thereby, there is foreshortening of the handle of malleus. Become more horizontal. Prominent lateral process of malleus and loss of light reflex. These 3 signs are a sign of retracted tympanic membrane. And there is mild conductive type of hearing loss. These 2 frequency of tuning fork give you a Rini negative result. তোমাদের রিনি পড়ানো হয়েছে? ফিজিওলজি পড়ানো হয়নি না? রিনি টেস্ট, রবিবার টেস্ট এগুলো বলেছে? tuning fork test. So in stage 1 we will get a negative Rini in these 2 frequency, 256 and 512. Then stage 2. Stage 2 is prolonged tubal occlusion, facilitate invasion of the pathogenic organism. Now infection starts in the middle ear exudate. There are mucosal hyperemia, inflammatory exudate in the middle ear. Symptoms are more marked now. Throbbing pain, tinnitus, deafness increases. Constitutional symptoms appear due to absorption of the bacterial toxin. There is high degree of fever, malaise, child become restless. What are the signs? Pars tensa is congested, bulge out with cartwheel appearance. What is cartwheel appearance? It is cartwheel appearance due to congested blood vessel along the handle of malleus and at the periphery of the TM. You have to know the blood supply pattern of the tympanic membrane. There is central blood supply coming from the handle of malleus and peripheral supply around the annulus. Later whole TM become red and right lip flex is lost. Most important, right lip flex is lost and TM pars placida get uniformly congested. Total uniformly congested TM. Deafness increases, so further add 1012 Hz frequency tuning fork. It is also really negative. This is the picture of second stage of tympanic membrane. This is the full congestion of the tympanic membrane. Now stage of suppuration. Pus formation start in the middle ear as well the mastoid ear cells. TM starts bulging. Gradually exudate increases and TMs become bulging. Excruciating pain. Severe pain is there. Deafness increases, all the symptoms become more and more. High temperature, headache. There may be convulsion also, vomiting and diarrhea in case of child. Sign, what are the signs? TM appears as red and bulge with loss of all landmarks. Here all landmarks are lost. You cannot see any landmark of the tympanic membrane. There is a center which appears like yellow nipple. It is the area of avascular necrosis. Appears like yellow nipple. Where perforation occurs. This perforation is more vulnerable to ischemic necrosis. Small amount of pus come out by drop. There is plenty of pus inside the middle ear cavity, but there is inadequate drainage due to small tiny perforation. So, giving rise to a lighthouse sign. What is lighthouse sign? There is drop of pus with reflect light. Light disappear when small drop of pus fall down. Again, small drop of pus will come out and reflect the light same way, as if there is a light is seen. This is called lighthouse sign. This is due to pulsatile discharge, nothing else. It is the pulsatile discharge due to arterial pressure change. Now stage of resolution. Stage of resolution after perforation, pus comes out and symptoms automatically subside. Blood stain discharge, ear pain, other symptoms are subsides. As the pus is coming under pressing the heartbeat with treatment giving after the come out from the middle ear, infection is controlled. The perforation may heal or may not be healed. Factors failure of resolution. What are the factors? Lack of resistance of the host, inadequate treatment and drug resistance. Stage of complication. When the virulence of the organism is high and the resistance of the patient is low, the treatment is poor, infection may spread beyond the middle ear space. Complication occur in the second week. Constitutional infection sign or symptoms reappear. Spread of neighboring structure beyond the limit of pericostal lining. There is demineralization of the safety between the ear cell. It is called coalescence of the air cells of the mastoid air cell system, giving rise to coalescence mastoiditis. Diagnosis, acute otitis media কি করে ডায়াগনোস করবে? It is a clinical diagnosis from the history. There is associated onset of signs and symptoms, tympanic membrane, condition of the miliary mucosa, tuning fork test, detection of the conductive hearing loss. So, there is a history of upper respiratory infection before earache and after earache. You can see what are the stages patient comes to you. In stage 1, you will get just retracted TM. In stage 2, you will get a cartwheel congestion. In stage 3, a burst tympanic membrane. In stage 4, you will get pus is coming out. So these are clinical signs and symptoms of diagnosing the acute otitis media. CT scan of temporal bone indicated only in refractive cases. So CT scan is not necessary routinely. In refractive cases, you can do a CT scan. Bacteriological examination. It is swab taken from the ear discharge for culture sensitivity to know the organism and the drug sensitivity. Now treatment. Aim of treatment is control of infection to give symptomatic relief and patency of the Eustachian tube. Symptomatic rest, sedation to reduce pain, analgesic, antipyretic, paracetamol, pain relief and reduce temperature, dry local heat to reduce pain. Broad spectrum antibiotic to start with, Comaxiclav and the dose of 80 to 90 milligram per kg per day, amoxicillin component 6.4 mg per kg per day and carbamazepine component. Oral cefuroxime axetil 30 mg per milligram per day, 250 milligram twice daily. Intramuscular IM, ceftriaxone sodium 50 milligram per kg on 3 consecutive days. Nasal decongestant used 1% ephedrine or atropine or nesibion like that to decongest the Eustachian tube opening. Surgery is Myringotomy is indicated in case of otitis media to relieve excessive tension of pus. When the TM is bulged and is about to rupture, pus is coming through these tiny perforations, still the patient is not relieved of pain at discharge, discharge is insufficient. So it is a deliberate drainage of the middle ear to clean the middle ear pus. It is to be remembered that delay in myringotomy may lead to large type of perforation with other complication of ASOM. Cortical mastectomy may be needed in case of coalescence mastoiditis. I already told you, if there is destruction of the air cell safety, there is accumulation of pus in the mastoid antrum, and there is a necessary of cortical mastectomy. Myringotomy. What is myringotomy? It is an incision of TM for therapeutic purpose. Usually done under GA, general anesthesia. It can be done in local anesthesia also. There are two types of incision in myringotomy. One is antero-inferior quadrant, that is in otitis media with effusion, and posterior-inferior quadrant in case of acute otitis media. Complication of myringotomy, loss of taste. Why? Due to injury to the cauda tympani nerve. Ossicular chain damage, giving rise to deafness. Hemotympanum, injury to the high arch jugular valve. Jugular valve comes in relation with floor of the middle ear cleft. And sometimes there is no bone, only directly it is exposed to the middle ear. you can injure during surgery the jugular bulb. One is acute otitis media, another is secondary otitis media or otitis media with effusion. This is a cotton wool soaked with ephedrine or like that, adrenaline. This is the tympanic membrane of the right side. You can see. This is called sickle knife. Putting an incision at the antero-inferior quadrant. Antero-inferior quadrant. This is your this is ambo. The handle of malleus, ambo. There is a doing a perforation. You can see secretion is coming out. You can see serosanguinous fluid is coming out. तो अच्छा है. So this is the secretion coming out. We are doing the suction of the secretion, thick glue-like material. This is antero-inferior quadrant, antero-inferior. Now, I am putting a ventilation tube or called Grommet tube. This is Grommet tube. This is the flange to secure the tube. It will go inside the deep to the tympanic membrane. Press it, it will fit in the perforation done by the Myringotomy. Why are you putting this tube? It will ventilate the middle cleft. After ventilating the middle cleft, automatically the blocked Eustachian tube open up. Eustachian tube is blocked, that's why this disease is developed. So through this perforation, ventilation will occur. And this tube is automatically gone out. If not within 3 to 4 months, we can remove the tube. This is done on the opposite side. This is left ear. Previous one is right ear. So this is antero-inferior quadrant. On the left side of the picture is antero-inferior quadrant. This is adrenaline-soaked cotton wool to hemostatize the tympanic membrane to prevent the bleeding. This is the sickle knife. Put an incision on the anterior-inferior quadrant. This is the anterior-inferior quadrant. You can see there is no discharge is coming out. Why? Can see this year there is no discharge. Why? Sometimes there is spontaneous drainage of the middle ear fluid after general anesthesia. General anesthesia cause relaxation of the Eustachian tube muscles, giving rise to automatically drain out of the secretion into the nasopharynx. That's why there is a dry tap. Okay. Grommet is in position. Tube opening is sucked out to clean any blockage. Thank you. ঠিক আছে, কোনো কোশ্চেন থাকলে জিজ্ঞেস করতে পারো।